In our clinic, usually we order 2 semen analyses when we have patients presenting with azoospermia, because there is some transient azoospermia that could be due to medical conditions, biological variability. So it's very important that you confirm at least twice after centrifugation that the patient has indeed facing azoospermia condition. So in our center, we have about 35% of our patient population presenting with azoospermia. We are an infertility center dedicated to male infertility. So in our condition, we see lots of patients with azoospermia due to the nature of our center. When I look at the type of azoospermia we have in our center, and then basically we have 3 types of patients presenting with azoospermia. We have a small proportion of patients with hypogonadotropic hypogonadism. I will explain later on. We have 1/3 of our patients with obstructive azoospermia, and the vast majority in our scenario here at Androfert, these patients present with spermatogenic failure, which is non-obstructive azoospermia. Hypogonadotropic hypogonadism is also a type of non-obstructive azoospermia, but this is a completely different condition because it is related to lack of proper stimulation from the gonadotropins coming from the pituitary to stimulate sperm production. We will go through these conditions more and more during this presentation. One thing that is very important for you to understand is that we need to make the differential diagnosis between the types of the azoospermia conditions I just presented in the previous slide. So if you take the medical history, the physical examination, and endocrine profile, you will be able to identify the type of azoospermia in approximately 90% of cases. So the medical history could indicate if the patient has got, for instance, cryptorchidism, mumps or orchitis, testicular trauma, torsion, that could indicate testicular failure. Some congenital abnormalities could also indicate the presence of obstructive azoospermia, for instance, some infection, pulmonary infection that could be related to cystic fibrosis. When you go for the physical examination, you can actually appreciate if the testes are of normal size, the epididymis is consistent in size, and if the patient has the presence or not of the vas deferens. For instance, if the patient has congenital bilateral absence of the vas deferens, this condition is related to obstructive azoospermia. So then you go for the endocrine profile, in which you have to look at FSH levels and testosterone levels as minimum standards. And then in many cases, you add LH levels, thyroid hormones, and prolactin. So the medical history, physical examination, endocrine profile is very important to actually discriminate between obstructive and non-obstructive azoospermia. Why is that important? Well, it's very important because prognosis and management of azoospermic patients will be affected by the type of azoospermia. So obstructive azoospermia refers to occlusion of the ductal system. In this case, obstructive azoospermia, the clinical picture will be a patient with normal testicular size, normal FSH, and total testosterone levels. So in this case, spermatogenesis is normal. The problem is that there was a mechanical block in the ductal system. And then the question will be, will you be able to actually reconstruct the ductal system and provide the patient an opportunity for natural pregnancy, or shall we use sperm retrieval and ICSI? So on the other hand, we have non-obstructive azoospermia, which is defined by the absence of sperm in the ejaculate due to lack of production of mature sperm. So non-obstructive azoospermia has to be divided in spermatogenic failure and hypogonadotropic hypogonadism. So then I was discussing about the spermatogenic failure, one type of non-obstructive azoospermia. So in this condition, we may have the testicular size that might be small or normal. FSH levels and LH levels, they could be elevated or normal. And total testosterone levels, again, low or normal. This is actually the clinical picture related to the physical examination and also the actually endocrine profile. Hypogonadotropic hypogonadism is completely different scenario because in this case, the testicular size will be reduced, the virilization is going to be poor, and the FSH and LH levels will be very low, below 1.2 milli-international units per ml, and testosterone levels will be below 300 nanograms per deciliter. So the common feature between spermatogenic failure and hypogonadotropic hypogonadism is that in both conditions, spermatogenesis is disrupted. But then management will differ completely because in hypogonadotropic hypogonadism, we have an opportunity to actually provide medication for the patient, gonadotropins specifically, to actually make the testicles make sperm, mature sperm. By contrast, spermatogenic failure, we don't have much to do in terms of actually making the condition normal. This is impossible. It's untreatable condition. So in that case, what we need to do is try to find an opportunity to increase the chances of finding mature sperm in the testicle by sperm retrieval and then use for ICSI. So let's discuss more about obstructive azoospermia that, as I said, relates to absence of sperm in the ejaculate due to occlusion or absence of the ductal system. The sites of obstruction could be in the ejaculatory ducts, could be in the vas deferens, or could be in the epididymis. So sometimes we see a patient without the vas deferens. This is congenital bilateral absence of the vas deferens that usually comes with hypoplasia of the ejaculatory ducts and also sometimes absence or partial absence of the epididymis. So it could be related to actually mechanical block or absence of part of the ductal system. So one condition, one etiology is congenital bilateral absence of vas deferens, but it's not the only condition actually related to a congenital abnormality. Sometimes we see ejaculatory or prostate cysts that actually obstruct the ductal system. Acquired conditions related to obstructive azoospermia, we have plenty. It could be related to post-infection, for instance, epididymitis, prostatitis, or seminal vesiculitis. Post-surgical conditions are related to previous vasectomy, hernia repair, epididymis surgery. Sometimes some doctors actually take out spermatocele, which is a benign cyst involving the epididymis, and this could cause obstruction. Scrotal surgery as well, because sometimes during scrotal surgery, we might injure the vas deferens. The bled neck surgery, prostatectomy, or could be iatrogenic, some endoscopic intervention, urological intervention that could actually cause block. And in certain circumstances, we don't have a clue why the patient has obstructive azoospermia. So as I said, these patients have normal spermatogenesis. So obstructive azoospermia will be always a favorable prognosis for fertility. We have two options then. If the condition is reversible, we might discuss with the patient possibility of reconstructive surgery or sperm retrieval. depending on the female factors, depending on the patient preferences. But if I have a condition which is non-treatable, like a congenital bilateral absence of the vas, or after a failed reconstruction, sperm retrieval and ICSI is the next step. So microsurgical reconstruction of vas deferens is highly successful in skilled hands. We can have, for instance, possibility to do microsurgical vasovasostomy or microsurgical vasoepididymostomy with good patency rates that can go up to almost 100% in certain circumstances, and pregnancy rates varying from 35 up to 80%. So obviously it will depend on the age of the wife, and also the interval, the obstruction interval. The longer the obstruction interval, the lower the success rates in terms of reconstruction. So in our scenario in Brazil, for instance, we see a lot of patients with vasectomy, and then some patients come to the clinic to discuss possibility of having vasectomy reversal. So this surgery, when we do with a microscope, is quite successful. This is an opportunity for actually making the patient have normal sperm in the ejaculate, and also possibility of having natural pregnancies. This is one opportunity. The second point related to obstructive azoospermia, and I believe this will interest you more, will be sperm retrieval. In this condition, we can offer the patient several options. We can offer percutaneous sperm retrieval techniques, such as percutaneous epididymal sperm aspiration. We can also offer microsurgical epididymal sperm aspiration. We can offer testicular sperm aspiration by needle aspiration. And we can also offer open testicular sperm extraction. So the options are plenty. Regardless of the techniques, it will be easy to actually identify sperm using these operations. Last week, I presented the video about percutaneous epididymal sperm aspiration to you. So I will not go through that video again. Today, I will present one video about testicular sperm aspiration and the way we do at the clinic. See, we have a 20 ml syringe, a large needle. We have this procedure is done with intravenous sedation with propofol. I apply some xylocan around the spermatic cord, and I use the loops to avoid actually puncturing vessels that I can see through the skin. And I use this 20 ml syringe connected with the Cameco syringe holder that you can see, which is very nice to create the negative pressure. And then I move the needle in and out without taking it out of the testicle. And I can take easily a nice piece of tissue, as you can see, that is going to be actually processed in the IVF lab and then used it for ICSI, immediate ICSI, or we can actually do cryopreservation of sperm, because usually these patients have plenty of sperm to use for ICSI and also for cryopreservation. So you can use the percutaneous epididymal sperm aspiration with the needle. We can use the testicular sperm aspiration, and we can also use the microsurgical epididymal sperm aspiration, which is called MISA. MISA is interesting because we can collect a lot of sperm. We usually start MISA doing a small testicular biopsy to confirm the patient has normal spermatogenesis. And in this video, you see that now I'm palpating the epididymis, and I can identify easily with the microscope enlarged epididymus tubule. So you can see enlarged epididymus tubule. We use the bipolar calthray actually to make a vascular plane in the epididymis tunica. Using micro scissors, we open the tunica, we dissect the enlarged epididymis tubules, and we cut these tubules. And then we start actually to aspirate the fluid coming out. So as you can see, I'm now aspirating the fluid. I can move to a different position, and then I could take a lot of sperm actually for cryopreservation. So this is a procedure that we can do just once, collect sperm, freeze sperm, and then allow the reproductive endocrinologist to perform the IVF cycle the way they like. The only thing we need to do will be to thaw the frozen sperm and then use for ICSI. So you can use the most, let's say, simple percutaneous epididymal sperm aspiration or even testicular sperm aspiration, or you can use the microsurgical epididymal sperm aspiration. As you can see in this table, the sperm retrieval rate is virtually 100%. The number of sperm harvest is going to be higher with MESA as compared with PISA and TISA. With MESA, we'll be able to do cryopreservation in 100% of cases. I mean, I can use fresh and then I will have enough sperm for cryopreservation, or you can do MESA beforehand and then plan the IVF cycle subsequently. So obviously MESA is more complex because we need the operating theater, the operating microscope, and it's more like an intervention procedure compared to PISA and TISA, but both of them provide an opportunity to collect sperm for ICSI, and then the cycle could be planned accordingly. So in our scenario right now, we use a lot of microsurgical epididymal sperm aspiration because we do these procedures beforehand. We collect sperm, we analyze, we freeze. We can also do, let's say, collection from the testicle and from the epididymis at the same time. We can compare rates of sperm DNA fragmentation between epididymis and testicular specimens, and then subsequently, in the ICSI cycle, we can choose the best specimen to use for ICSI. So this is an opportunity to kind of actually provide the patient an opportunity using the best quality sperm that we could retrieve. In this paper we published a few years ago, we look at sperm retrieval rates and ICSI outcomes in patients with obstructive azoospermia. As you can see in the graph, we have patients with CBAVD in our patient population, post-vasectomy and post-infection. And as you can see, the sperm retrieval success rates, I mean, in this study, we defined sperm retrieval success rates as presence of motile sperm. It was virtually 100%, regardless of the etiology. When we look at ICSI results, and you can see in the right-hand side of the screen that we compared in one study ICSI outcomes in patients with obstructive azoospermia as compared with ICSI using sperm obtained from donors. So in this case, it was a group of 40 patients in which the male partner had non-obstructive azoospermia. We tried to collect sperm from the testicle, but we did not succeed. And then in these cases, these patients opted to use donor sperm. We compared the ICSI outcomes among patients using donor sperm with obstructive azoospermia, and as you can see, results are very similar. So the message here is that in obstructive azoospermia, it's easy to harvest sperm from the epididymis or the testicles. And when we do ICSI, results are as good as if you have used sperm from donors. So the prognosis is very good. Concerning obstructive azoospermia, the key issues is that the sperm retrieval techniques and cause etiology of obstruction have little impact on retrieval rates. So you can use the percutaneous retrievals, which are the simplest methods, but MISA provides higher sperm yields, which might be advantageous regarding sperm cryopreservation, as I explained previously. The sperm chromatin integrity seems to decrease towards the distal portions of the obstructive seminal tract. So if you decide to go for the epididymis aspiration, I would recommend you to start in the mid portion of the epididymis, and then you can move cranially if you don't find enough motile sperm for ICSI. Concerning pregnancy outcomes with the epididymal and testicular sperm, or using fresh or frozen thawed sperm, different causes of obstruction. All these conditions do not seem to play a significant role in terms of pregnancy outcomes using ICSI. You can use either epididymal or testicular sperm. You can use fresh or frozen thawed sperm. And regardless of the cause of obstruction, ICSI outcomes will be quite similar. So again, obstructive azoospermia is a very good condition in terms of actually providing our couples the opportunity to have a baby. And concerning the health of offspring, with surgically extracted sperm from men with obstructive azoospermia, results in the literature are quite reassuring. We don't see major differences in health of offspring when we compare patients with obstructive azoospermia and patients using ejaculated sperm for ICSI. Now I want to move to the next point, which is non-obstructive azoospermia. So we have two conditions in non-obstructive azoospermia, which is the absence of sperm in the ejaculate due to lack of production of mature sperm. Let's discuss, first of all, hypogonadotropic hypogonadism. As I said, this condition is associated with reduced testicular size. There's poor virilization because the patient has low testosterone levels. And the reason why there is lack of production of mature sperm is because FSH and LH levels are quite low due to lack of release or production of these gonadotropins by the pituitary. This is why the spermatogenesis is disrupted. So in this condition, the absence of spermatozoa is due to lack of adequate stimulation by pituitary gonadotropins. It could be due to congenital conditions such as Kalman syndrome. We can also have normomisk hypogonadotropic hypogonadism, and some congenital abnormalities such as Prader-Willi syndrome. These congenital conditions are related to lack of adequate communication between the hypothalamus and the pituitary. So the pituitary will not get the proper stimulation to secrete the gonadotropins. We have also acquired conditions related to hypo-hypo. For instance, any surgery in the pituitary that could be a prolactinoma, for instance, could be infection, could be encephalic trauma, brain irradiation, or pituitary irradiation. Even systemic diseases could actually cause acquired hypo-hypo. Lastly, one condition that we see more and more in our clinic these days, patients using testosterone replacement therapy. Because when we take testosterone exogenously, it will cause supraphysiological testosterone levels. It will be greater than 1,000 nanograms per deciliter. So this testosterone replacement therapy will block the pituitary. That will stop releasing LH and FSH, that are the important hormones to actually sustain spermatogenesis. So we need FSH to act on the Sertoli cells to kind of stimulate spermatogenesis, but we also need LH, because LH will act on the Leydig cells, making intratesticular testosterone that will be very important to actually work in combination with FSH to sustain spermatogenesis. So acquired conditions could also be related to hypo-hypo. You need to kind, in the medical history, try to understand if the patient has any of these conditions listed in this table. And could be idiopathic. So when you have a patient in front of you who is azoospermic, and you see that FSH and LH levels are quite low, below 1.2 international units per liter, you need to make the diagnosis of hypo-hypo and make medical history trying to identify if the patient has any condition that could be explaining the reason why he has hypogonadotropic hypogonadism. Another important thing that you need to do during the physical and the medical history is like to identify if the patient with hypo-hypo has got this condition pre-pubertal or it was a late onset hypo-hypo. This is very important because you can see the different pictures. A patient with pre-pubertal hypo-hypo, it's more like unicaudal stature, the testes are very small, the patient has no virilization at all. Obviously, the patient has azoospermia. By contrast, post-pubertal hypogonadism, the testicles are usually more developed. They are not so small as compared with patients with pre-pubertal hypo-hypo. We see some virilization, as you can see in the pictures in the bottom part of the slide. The patient has infertility, most often azoospermia. In some cases, we see, let's say, severe oligozoospermia. But the secondary sexual differentiation in post-pubertal patients with hypo-hypo has been achieved. So in this case, the patient has normal voice, normal prostate, and the penile length is of normal size. So this is important actually to differentiate both conditions. Post-pubertal hypo-hypo usually relates to pituitary surgeries, encephalic trauma that could actually be the cause of lack of FSH and LH, secondary to conditions affecting the pituitary after the puberty. Well, then we need to discuss therapeutic management for hypo-hypo patients desiring fertility. One option would be to give these patients the GnRH pump treatment, which relates to the subcutaneous administration of pulses of GnRH every 2 hours with dose that varies. But this is restricted to patients with GnRH deficiency. So for instance, patients which has Kalman syndrome, that could be actually an opportunity to treat these patients with GnRH pump treatment. However, the treatment requires many times a expensive medication and sometimes with need to kind of implant the device subcutaneously that will release the GnRH pulses every 2 hours. In general, the best options for patients with hypo-hypo is actually gonadotropin treatment. Because with gonadotropin treatment, for instance, HCG, that could be used as a monotherapy, or HCG plus FSH, actually we can treat both prepubertal and postpubertal hypogonadotropic hypogonadism. So in our clinic, we prefer to use HCG monotherapy in case in which hypo-hypo is postpubertal, and in case we have prepubertal hypo-hypo, we need to add both HCG and FSH, and we also add FSH in postpubertal hypo-hypo refractile to HCG monotherapy alone. So how we use it? Concerning HCG, we give 1,000 to 2,500 international units twice a week, at least 3 months. Sometimes patients respond faster, but you need to consider that it may take up to 6 months actually to have sperm production. If the patient is prepubertal, we need to give HCG and FSH. We usually give 75 to 150 international units of FSH 2-3 times a week for up to 18 months. It will take longer for a prepubertal patient to have mature sperm in the ejaculate. So you should not expect normal sperm count after gonadotropin treatment in patients with the hypo-hypo. Usually these patients will have mild oligozoospermia, but still these patients will be able to impregnate their wives naturally most often, or with the use of assisted reproduction. It could be IUI or IVF-ICSI, depending on the condition. So patient with hypo-hypo will have restoration of spermatogenesis in up to 90% of these patients. What you see will be increase in testicular size, you see complete virilization, and restoration of spermatogenesis in 9 out of 10 patients with hypo-hypo. In this study we published some time ago, we look at a group of patients with adult onset hypogonadotropic hypogonadism. For instance, patients who have taken testosterone replacement therapy, who had pituitary surgeries, etc. These patients we treated with recombinant HCG once a week for 12 weeks. We gave 1 injection per week of recombinant HCG, 250 micrograms per week. So it is 250 micrograms is like 6,750 international units. So about 7,000 units per week. What you can see in the top part of the slide, you see the patient before treatment, baseline condition, you see poor virilization, and we cannot even see the scrotum is very poorly developed. Now, after treatment, you see the virilization was much better, and you can even see the scrotum with the testicle actually, in this case, increased in size dramatically. So from baseline, the total testosterone levels were 41 nanograms per deciliter, and after treatment, it climbed up to 647.5 on average. Here you can see the mean combined testicular volume from 24 and then climbed up to 33. And the sperm count in this group of patients actually, average was 36 million per ml. So we prefer to use recombinant FSH because we can give the patient injection per week, or we can split the dose, the dosages twice a week. We can titrate the amount of HCG to kind of achieve the testosterone levels around 600 to 800 nanograms per deciliter, and then we can actually follow up the patients doing hormonal measurements and also semen analysis until we have enough sperm for conception. That could be natural conception, that could be IUI or IVF. However, the use of recombinant HCGs off-label therapy, it's important that for you to know that. So if you decide to give recombinant HCG, which is very poor, the molecule is very good, we can use subcutaneous administration. The patient can do by himself at home, doing the self-administration. You need to inform the patient that it's off-label medication. Now I want to move to the last point, which is spermatogenic failure. And this is a very important condition because it will represent most patients we see in the clinic. These patients will have usually reduced testicles, they will have high FSH and LH levels and low testosterone levels. Let's explore this situation in detail, because these patients, they are not necessarily sterile patients. We see residual spermatogenesis in about 50% of cases. So this is important. The figure here, what you see, the illustration represents two Sertoli cells. The yellow cells that you see here are the Sertoli cells. And in the bottom of the figure, you see the spermatogonia. And then we have spermatocytes. Then we have spermatids. And then we have sperm. So we can have residual spermatogenesis in about 50% of cases. The problem is that in patients with non-obstructive azoospermia due to spermatogenic failure, the geographic location is unpredictable. I don't know where this residual spermatogenesis is. So we need to do something. And the thing we need to do is obviously sperm retrieval, but we need to apply a technique that will be able to increase the success rate. So the way we manage patients with non-obstructive azoospermia due to spermatogenic failure includes proper evaluation. We provide the patients a fair estimate of the outcome, the possible outcome, counseling. And then we develop a time-limited treatment plan. Because in some circumstances, we feel there is no point of actually repeating treatment of failure after failure. We need to provide the patient, let's say, a treatment that has beginning, middle, and end. And if the patient is not achieving that result, then the patient should consider other opportunities, such as sperm donation, if this is allowed, or even adoption. So this is the algorithm that I published a few years ago in Asian Journal of Andrology. I shared this literature with you, which is the clinical management of infertile men with non-obstructive azoospermia in 5 steps. So this is an algorithm that we start with the differential diagnosis of azoospermia. We have gone through these steps before because it's important to make the clinical diagnosis of obstructive azoospermia, hypogonadotropic hypogonadism, and non-obstructive azoospermia due to spermatogenic failure. These are 3 different conditions. So when I make the diagnosis of non-obstructive azoospermia due to spermatogenic failure, I need to counsel my patients about the chance of finding sperm for ICSI. And then I will explain to you that we need to integrate molecular genetic diagnosis. Next step is going to be the selection of sperm retrieval candidates who might benefit from any intervention that could eventually increase the sperm retrieval success rates. Then we need to apply the most effective surgical method for sperm acquisition and then utilize the state-of-art laboratory techniques to actually cultivate the gametes and do ICSI to improve the outcomes. So again, just to reinforce the definition, the concept that non-obstructive azoospermia due to spermatogenic failure relates to lack of production of mature sperm due to intrinsic testicular deficiency. The condition could be congenital, like testicular dysgenesis, cryptorchidism, could be genetic, like Klinefelter syndrome. We have seen the genetic conditions in the previous lesson. Could be related to microdeletions affecting the long arm of the Y chromosome. Could be to other genetic conditions like XX male, androgen receptor mutations, etc., etc. Could be also acquired non-obstructive azoospermia related to testicular torsion or trauma that causes testicular hypertrophy. Could be post-infection like mumps or caries, exogenous factors such as irradiation, chemotherapy, testicular cancer, systemic diseases, and could be also idiopathic. So medical history, physical examination, and endocrine profile, and then you'll be able to identify most of patients with non-obstructive azoospermia due to spermatogenic failure. Next step is going to be counseling these patients regarding chances of finding sperm for ICSI. So the first important message I want to give you is that the chance of finding sperm among men with non-obstructed azoospermia due to spermatogenic failure do not relate very much to the etiology of non-obstructive azoospermia. As you can see, sperm retrieval success rates are quite similar in patients with cryptorchidism, post-infection, torsion, post-chemotherapy, radiotherapy, or idiopathic. The only condition that will play a role in the sperm retrieval success rate is genetic conditions, most specifically in patients having problems with the Y chromosome that I'll go through in a minute. So etiology is not that important. So you cannot exclude a patient from treatment by the etiology. If the patient presents to you with a history of chemotherapy, very high FSH levels, low testosterone levels, and reduced testicular size, do not deny the patient the opportunity to have sperm retrieval, because even in this condition, the patient could get sperm to ICSI. So etiology does not play a major role in sperm retrieval success rates. Diagnostic markers such as FSH levels, testosterone levels, and testicular volume, they give only a picture of the global testicular function. They will reflect the global testicular function. So if I have a patient with high FSH levels, low testosterone levels, and the small testicles, what it means is that this patient have global testicular deficiency. But these markers are not accurate to predict whether a site of active spermatogenesis exists in the testicle. The only way to actually confirm will be doing sperm retrieval. So do not rely on FSH, testosterone, and testicular volume to deny the patient the opportunity of having sperm retrieval. The only marker that could be used to counseling in terms of biomarkers will be testicular histopathology. This marker have an accuracy of 80% to predict chances of finding sperm. So in this study we published some time ago, we look at sperm retrieval success rates according to testicular histopathology. And here you can see three different scenarios. We may have a patient with hypospermatogenesis. Hypospermatogenesis means that the patient have all layers of spermatogenesis in the testicle, but these layers are reduced in size. So the patient have spermatogonia, spermatocytes, spermatids, and even sperm, but in reduced, let's say, quantities. In this case, the chance of finding sperm is quite high, as you can see. The other condition is maturation arrest, in which we find sperm in about 40 to 50% of cases using sperm retrieval. And in these cases, the spermatogenesis is arrested at some point. It could be at the spermatogonia level, could be at the spermatocyte level, or could be at the spermatid level. And the last condition is Sertoli cell only, in which still in this very dramatic scenario in which the testicular biopsy result only shows the presence of Sertoli cells, no sperm, no germ cells at all, still we will be able to find residual spermatogenesis in 20% of patients with Sertoli cell only. So although the testicular histopathology could provide some guidance or an opportunity for discussion, counseling opportunities, please do not deny a patient with testicular biopsy results showing Sertoli cell only the opportunity to have sperm retrieval, because in this case, which is the worst case scenario, we might be able to find sperm in 20% of cases. Well, we do not advocate testicular biopsy to our patients. But sometimes the patients come from the urologist who has done the biopsy outside, and the patient comes with the testicular histopathology report. So use that report for counseling. We do not advocate doing the testicular biopsy, because if you do the biopsy just for the purpose of diagnostic, obtaining the diagnostic report, you might take a residual area of spermatogenesis out. You send to the pathologist, you get the report, but the patient could not have another area of residual spermatogenesis when you actually go and do the sperm retrieval for ICSI, and the patient has lost the last opportunity of having a biological child. So the testicular histopathology, if you want to do a biopsy, it has to be inside the clinic, a fertility clinic, I mean, in which you'll be able to send the specimen to the IVF lab. The IVF lab will provide you process the specimen, check if there's any sperm, and if there's sperm, they freeze, take just a part of this extracted specimen and then send to histopathology. But do not do diagnostic testicular biopsy just for the purpose of actually having the report, because you might compromise the chances of future sperm retrieval. What is very important to offer these patients is actually the genetic analysis concerning the Y chromosome, because in this region, as I explained last week, the long arm of the Y chromosome contains the essential genes involved in spermatogenesis. So in the long arm of the Y chromosome, we have a region called AZF, which refers to Azoospermia factor. And this region, AZF, is divided in three actually portions: AZF-A, AZF-B, and AZF-C. And these three regions contain essential genes for spermatogenesis. So what we need to do is a multiplex PCR in which we will analyze the long arm of the Y chromosome. And then using the PCR, we will be able to actually compare with always running a control. Like as you can see, the number 4 is a normal male, in which using the PCR electrophoresis, you see that the markers of AZF A, B, and C, they are here. So it means the patient has everything normal, nothing is missing in the long arm of the Y chromosome. But in contrast, you have a patient, for instance, in which a marker for the AZF-B region is missing. So this patient has AZF-B microdeletion. Or you can have a patient like number 6 here, in which the marker for the AZF-C region is missing. So you can see if the patient has any piece, any microdeletion. Sometimes they come combined. Some patients, they have combination of AZF-B and C, or even complete deletion of the long arm of the Y chromosome. Why is it important? Well, because the presence of Y chromosome microdeletion has prognostic value. For instance, if the report comes with a deletion involving the AZF-A region, there is no point of offering this patient sperm retrieval, because this patient will not have any sperm in the testicle. There's no residual area of spermatogenesis. So it's important to read the chapters related to spermatogenesis. We have chapter A, chapter B, and chapter C is like a book. And then if chapter A is missing, don't offer patients anything else. The patient should be offered adoption or even donor sperm if it's allowed. AZF-B is, again, very poor prognosis for actually retrieving sperm. In virtually all cases of AZF-B microdeletions, we won't be able to find any sperm within the testicles. However, the AZF-B is a long, let's say, region with many genes, and it has been described some partial deletions involving the AZF-B region in which sperm could be found. In our center, we have 2 cases of partial AZFB microdeletions with sperm. We were able to find sperm used for ICSI and provide these couples biological offspring. But it's very rare. So overall, we can say that for patients with AZFA and AZFB, they are not candidates for sperm retrieval. By contrast, patients with AZFC, they have overall success rate of 50% when they go for sperm retrieval. So for patients with AZFC microdeletions, when they come along, we might discuss with these patients an opportunity to kind of go ahead with treatment and then offer sperm retrieval, because our chances of finding sperm will be around 50%. So after counseling about the chance of finding sperm for ICSI with Y chromosome microdeletion screening, we need to select sperm retrieval candidates who might benefit from interventions. So as I said before, patients with non-obstructive azoospermia due to spermatogenic failure, usually they have hypogonadism. However, this is not hypogonadotropic hypogonadism. In this case, is hypergonadotropic hypogonadism. Why? Because FSH and LH levels are usually high. The pituitary is trying to stimulate the testicles. But because of intrinsic testicular deficiency involving both the germ cells and the Leydig cells, the testosterone levels produced by the Leydig cells will be below the normal levels. So in this case, you have an opportunity to stimulate the Leydig cells to make more testosterone. And the rationale will be that the intratesticular testosterone levels are essential for spermatogenesis. And in patients with non-obstructive azoospermia due to spermatogenic failure, although FSH levels and LH levels are quite high, the Leydig cells are not properly stimulated because they are lacking in size. And then we might actually push the system with HCG, for instance, to make the Leydig cells make more testosterone. So in this case, we will be able to increase intratesticular testosterone levels, which has been shown to be essential for spermatogenesis. So the point here is that the stimulation of Leydig and Sertoli cells will be paradoxically weak due to the high baseline FSH and LH levels. Remember that the amplitudes of FSH and LH levels are quite important to stimulate the receptors at the target organs. So because the baseline levels of FSH and LH levels are quite high, these patients have high FSH, high LH, the stimulation is paradoxically weak. So by pushing the system, and there are several studies in the literature suggesting that by pushing the system with aromatase inhibitors, clomiphene citrate, HCG, and combination of drugs might actually increase the opportunity to find sperm within the testicles of men with non-obstructive azoospermia. We do not have any, let's say, prospective randomized control trial indicating that the medical therapy is beneficial, but we do have some observational studies, case series with retrospective cohort and prospective cohort studies actually with those results suggesting that could be beneficial. Well, in this slide, you see the results of a study in which the authors have used HCG therapy to increase intratesticular testosterone production in men with non-obstructive azoospermia. As you can see, the intratesticular testosterone before stimulation and after stimulation was quite different. So the intratesticular testosterone levels should be 100 times higher than the testosterone levels we see in the periphery, in the peripheric blood, to work properly. So when we check the testosterone levels in the peripheric blood and we get, let's say, 200 nanograms per deciliter, so the intratesticular testosterone levels usually is 100 times higher. So we need a lot of intratesticular testosterone to sustain spermatogenesis up to a certain limit. So using HCG therapy, we might increase intratesticular testosterone, and we might also stimulate spermatogonial activity. And this could actually make differentiation from spermatogonia to spermatocytes and to spermatid and to mature sperm, increasing the opportunity of having sperm inside the testicle. So in our center, we use an algorithm, a protocol that we developed to boost intratesticular testosterone production. The protocol has been published in a paper we published in Asian Journal of Andrology in 2015. I shared this literature with you. You can go through again, but briefly. We start with HCG twice a week, 1,000 up to 1,500 international units. We use HCG subcutaneously. I prefer giving these patients recombinant HCG because it's very easy to control and the patient can do self-administration. So I adjust the dose of HCG to keep the total testosterone levels that I check monthly around 500 to 800 nanograms per deciliter. So if you use the units as nanomole per liter, it should be between 17 and 28. Then, when we give HCG therapy, especially in overweight patients, they will have some aromatase conversion of testosterone to estradiol. And then estradiol levels might increase. That could block the pituitary. We don't need that. So in this case, we might add aromatase inhibitor if the testosterone to estradiol levels are below 10. So you make the ratio between testosterone and estradiol levels. So if the ratio is below 10, you might add aromatase inhibitor because it will block the conversion of testosterone to estradiol, and then you'll be able to get most of the testosterone the patient is producing endogenously. Then you need to monitor monthly the FSH and LH levels as well as the testosterone levels in about 1/3 of patients, 1 every 3 patients. The FSH levels will drop below 1.5 international units per liter. Because when you give HCG, you stimulate testosterone production. The testosterone will act in the pituitary as a negative feedback. And then LH levels and FSH levels will go down. This is normal when you give HCG therapy. However, if the FSH levels goes down below 1.5, then we lack the proper stimulation. And remember, the Sertoli cells has to be stimulated with FSH to actually have proper spermatogenesis. So in that case, if you see a patient after starting HCG therapy having low FSH levels, and then you might add FSH to treatment. Well, this might seem a little bit complicated, but it's actually very simple. I will present you 2 examples now of patients we have treated with this protocol and how we got good results. For instance, have a look at this patient with 46 years old. This gentleman, he has idiopathic non-obstructive azoospermia. He has a history of previous negative sperm retrieval by conventional testicular sperm extraction. So the baseline levels of FSH quite high, 32.6. LH levels in the upper limits is still within the normal range, and total testosterone levels is 194, which is below 300, low total testosterone levels. So what we did in this patient, we started the stimulation with recombinant HCG 1,000 units twice a week. So 1 month later, as you can see, the FSH levels dropped dramatically. The total testosterone levels actually increased, and now it's higher than 300. This is good result, but I was not quite satisfied. And I increased the HCG dosage. And then I increased it from 1,000 international units twice a week to 1,500 international units twice a week. So 1 month later, I checked the endocrine profile again, and here you see that FSH levels were even lower than before. LH levels below 1, which is very common when we give HCG therapy. This is okay. This only indicates that the patient is taking the medication properly, because you know HCG is like LH with longer half-life and more potent than LH in this condition. So here you see that after increasing the total testosterone, after increasing the HCG dosage, we have got higher testosterone levels, which is very good. And the ratio here between testosterone and estradiol levels is higher than 10. So I don't need to add aromatase inhibitor. So it's important when you make the ratio, you need to transform the units. It should be nanograms per deciliter, and estradiol level should be in picograms per ml. So if in your laboratory, the laboratory provides in different units, you need to first convert the units to nanograms per deciliter, picograms per ml to make the proper ratio that I described before. Well, I kept giving the HCG therapy for this patient for longer time. And after another 4 weeks, the FSH levels dropped to below actually 1.2, which is the threshold. Well, in this case, I need to add FSH, because if I decrease the HCG dosage to kind of release the pituitary a little bit, I might lose the testosterone levels that I have achieved. So in this case, I opt to add FSH. And in this case, I add recombinant FSH twice a week, 75 units. So after another month, I have got these results of FSH levels 1.8, which is quite good. Testosterone levels of 550, excellent. And then actually I was satisfied. Here you can see the graphic representation of the treatment, in which we started with a very low total testosterone levels, and it went up beautifully. The FSH levels were very high, and then it was going down, and then up to a certain point, we need to add some FSH. And then estradiol levels actually is like fluctuating a little bit. It's normal to have some increase in estradiol levels, because these patients, you have some aromatization in the fat tissue. They will aromatize testosterone to estradiol. If you need, you need to kind of add aromatase inhibitors. In this case, I did not do it. So, but the good news about this case is that when we did the microdissection testicular sperm extraction, remember, this patient has had a negative sperm retrieval in using conventional testicular sperm extraction. But after this hormonal modulation, we have got plenty of sperm, and we were able to freeze 6 vials using conventional freezing, and 4 vials using the cell sleeper method, which is like the sperm vitrification that we have introduced in our center. So I will explain a little bit more about cell sleeper later on, but just for now, I'm just presenting a good case in which we were able to kind of rescue a negative TESI result with hormonal modulation. This is another case we published recently, in which we did together with a group from Denmark, in which I do collaboration. So again, using the same protocol, we provided the hormonal modulation for a patient with non-obstructive azoospermia. In this case, the patient had 28 years old, and the etiology was cryptorchidism, normal karyotype, no Y chromosome microdeletion. Here you can see that the patient had hypertrophic testes of 8 cc, small testicles. FSH was not very high, but still above the limit or in the upper normal range, depending on the threshold that you use in your clinic. So 11 is like the ceiling in the laboratory we have used it. So 11. But remember, I said in the first talk I gave you about the male infertility workup, every time you have FSH levels above 7.6, you need to consider that the patient has testicular deficiency. Above 7.6, we need to consider that FSH is already high. Total testosterone levels, now they use nanomoles per liter. It was in the lower limits. This patient have got multiple azoospermic specimens after centrifugation. And the doctors there, they did diagnostic TISA in the center, and they were able to find rare, immotile, and only abnormal sperm not suitable for ICSI. So we discussed with the patient the opportunity to give hormonal modulation. So we started with recombinant HCG twice a week. So here we use about 1,500 units twice a week. So what happened 4 weeks later was that the FSH levels went down, the testosterone levels went up, but it was too high because our ceiling in nanomole per liter should be around 27, 28. So in this case, what I did, I decreased the HCG dosage from 1,500 to about 800 international units twice a week. So 4 weeks later, now we have good total testosterone levels, FSH levels, I mean, now 1.2, just reaching the threshold. So we opt to add FSH levels 150 international units twice a week because FSH levels was quite dangerous levels, 1.2. We wanted to have it a little bit higher. So we kept the same dosage of HCG and increased it and add FSH, as you can see. And what happened then was that we could actually increase the FSH levels to 1.5, but for some reason, the testosterone levels went down. Some patients, when you continue the stimulation for several weeks, they might have these fluctuations. What we did, we increased again the HCG dosage from 800 twice a week to 1,000 twice a week. So, and also we increased the FSH dosage to 225. And then we checked again, and now it was beautiful. Testosterone levels 25, FSH levels 2.2, and then we started to look at the semen analysis of these patients because we have been checking also the semen analysis. You see azoospermic, and surprisingly, after 24 weeks treatment, the patient started to have sperm in the ejaculate. So we started to freeze sperm using conventional approach, using the liquid nitrogen with the conventional vapor freezing method. But we could not actually get motile sperm after thawing. So we continued the stimulation and we changed the freezing method to the cell sleeper method, which is a vitrification method, which allows to cryopreservation of few sperm quantities. So in this case, we started doing the cell sleeper. We kept the patient with the stimulation, and then we use the frozen thawed sperm for ICSI. And in this case, the patient has got successful pregnancy by ICSI using frozen thawed ejaculated sperm from the cell sleeper. And then we reported this case because they reached a full-term live birth of a healthy baby boy with the hormonal stimulation of spermatogenesis in a patient with non-obstructive azoospermia due to cryptorchidism, in which we were able to restore spermatogenesis to a point in which sperm retrieval was not necessary. So here you can see two cases. Obviously, I'm presenting two successful cases, but just to highlight the importance of actually exploring the opportunity to provide some stimulation with HCG and eventually FSH to boost testosterone production and spermatogenesis. So this is one intervention that you might consider discussing with your patients with non-obstructive azoospermia before sperm retrieval. The other thing you need to consider discussing with your patients is possibility of treating a varicocele. So if the patient has a clinical varicocele, grade 1, 2, or 3, clinical varicocele means a varicocele that you can see, like a grade 3 varicocele that you see in the picture, or a varicocele that you can feel when doing the physical examination with or without the Valsalva maneuver. Well, these are the varicocele that could actually be treated, and eventually you could provide some beneficial effect in terms of sperm production. Why? Well, because the spermatogonia, the spermatocytes, and the spermatids, they are highly vulnerable to heat stress. And what actually the varicocele produce is actually heat stress. So the varicocele repair might improve spermatogenesis and androgen production in selected patients. In this paper we published in 2016, we look at studies in which the patients have been given varicocele repair to overcome or to help improve spermatogenesis related to non-obstructive azoospermia. We collected 18 studies. These are small cohort studies, including about 500 patients of non-obstructive azoospermia. And these patients were subjected to varicocele repair, most often microsurgical varicocele repair. And we found that 44% of men had some sperm in the ejaculate postoperatively. The sperm count was low, but the varicocele repair was able, according to this data, to rescue spermatogenesis to a point in which sperm retrieval was not necessary. And it happened in about 44% of patients. And in these patients, the histopathology was the only prognostic factor for sperm return to ejaculate. So what these doctors have done during the operation, including a study of our own that has been included in this systematic review and meta-analysis, what we do during the operation, we take a specimen from the testicle and send it to the pathology. So when the histopathology report shows hypospermatogenesis or maturation arrest, so the chances of having sperm in the ejaculates substantially bigger than when the patient has Sertoli cell only in the histopathology report. Well, the patient with Sertoli cell only, as I told you before, they still can have residual focus of spermatogenesis, but the chance of having rescue after varicocele repair is much lower than compare with patients with hypospermatogenesis and maturation arrest. So in this study, we realized that the varicocele repair could benefit about 1/3 of men by providing some sperm in the ejaculate. However, to out of 3 men remain azoospermic after varicocele repair. Despite of that, the varicocele repair by microsurgical varicocelectomy could actually increase the odds of sperm retrieval. So sperm retrieval rates among patients who have been treated, who have gone microsurgical varicocele repair before the sperm retrieval, they have got increased sperm retrieval rates in the studies comparing this outcome. Also, if only 2 studies in this case reported live birth among patients treated compared with those patients without the varicocele treated, in which sperm retrieval was performed and live birth by ICSI were compared. So in this case, the authors showed that there was an increase in live birth rate in the group of men who had the varicoceles treated and who have got sperm retrieved and injected by ICSI. So the live birth rates were actually higher in patients who had the varicocele treated. Well, this study suggests that in patients with non-obstructive azoospermia, in which there is a coexistent clinical varicocele, we might discuss with the patients an opportunity to increase sperm production that eventually will result in having some sperm in the ejaculate, or if not, it will increase the chances of retrieving sperm from the testicles and having better outcomes in terms of pregnancy by ICSI. So after actually providing the patient with interventions we discussed hormonal modulation and varicocelectomy, we need to apply the most effective method for sperm acquisition. So for patients with non-obstructive azoospermia due to spermatogenic failure, we can offer these patients testicular sperm retrieval methods. Remember, these patients should not be offered epididymis sperm retrieval methods, because in patients with non-obstructive azoospermia due to spermatogenic failure, the epididymis is not the target organ for sperm retrieval. We will not be able to find sperm in the epididymis. We need to go inside the testicle. And then we could offer these patients testicular sperm aspiration, testicular sperm extraction, or we can offer microdissection testicular sperm extraction, which is microTISI. So here we need to look at the success rates, because if you go for the aspiration, the needle aspiration, the extraction, and the microscopic extraction, we have different results. According to the data available in the literature, the microTISI is more likely to result in successful sperm retrieval than conventional testicular sperm extraction. On the left, you can see a study of our own group in which we compare the microTISI with the large single testicular biopsy, and we found better results with microTISI in all patient categories, I mean, in all histopathology phenotypes. And in the right, you can see a systematic review and meta-analysis in which the authors compared the existing data regarding controlled studies of microTISI versus conventional TISI, and they found 1 times higher sperm retrieval success rate using microTISI compared with the testicular sperm extraction. I will just go back a little bit to decrease the sound, and I will show you a video of the microdissection testicular sperm extraction. This is a very short movie, but just for you to appreciate the environment, we do the microTISI, which is in the clinic. We do it as an outpatient basis. So we do in the operating theater, just next door we have the IVF lab. And we do with the intravenous sedation with the propofol, and you'll be able to appreciate actually the identification of the enlarged seminiferous tubules. I'm doing the operation with my colleague, Dr. Miyaoka. And here you need to open the skin, you need to deliver the testicle, open the tunica albuginea, and expose the testicular parenchyma. Now, this is a picture that we can see using the operating microscope. And here you can see very easily a spot of enlarged seminiferous tubules that will be more likely to have active spermatogenesis. We take that spot out, so it's a microsurgical guided testicular biopsies, and then we send these specimens for the IVF laboratory personnel to process, and they will be able to kind of have a higher chance of finding sperm. So the issue is, the larger the seminiferous tubules diameter, the higher the chance of harvesting sperm in patients with non-obstructive azoospermia. So we have done a study in which we look at the diameter of the seminiferous tubules and the chance of finding sperm. And in the left side, you can see that the presence of sperm was significantly more likely in tubules with larger diameters. So in the left panel, you can see that after taking the specimens, we measure the diameter of the seminiferous tubules using the inverted microscope. And then you can actually look at the tubules. For instance, these are examples of very thin tubules. And this is an example of a very, let's say, enlarged tubule. And we did some studies in which suggested that the cut point of 206 micrometers is a good cut point to discriminate patients with higher chance of having sperm. And below that point, the chance of having mature sperm will be decreased. We are actually conducting an ongoing study in which we are collecting more and more data to define the best cutoff point for doctors willing to use the measurement, the intraoperative measurement, to actually identify the tubules with higher diameter. What we do in our center, actually, we have some special microsurgical forceps in which we ask the manufacturer to make the tip of the forceps with certain diameter. For instance, we can make the tip of the forceps with 260 micrometers, and then I will compare the tip of the forceps with the diameter of the seminiferous tubules I see through using the operating microscope. And I will take those tubules that match the tip of the forceps, because I use the tip of the forceps as a measuring device to identify objectively the tubules more likely to contain spermatogenesis. So this regards the application of the most effective and efficient surgical method for sperm acquisition. Now I want to move to the last point, which is the utilization of the appropriate laboratory techniques for handling the sperm we take from men with non-obstructive azoospermia. And here we have several things we need to consider in the lab. So this is more for the embryologists, but it starts with extraction of the minimum amount of tissue. With microTISI, we can optimize the tissue extraction process by providing the laboratory with the piece of tissue more likely to have sperm. So the chance of losing sperm in a sea of tissue, sea of cells, when we provide big pieces of tissue using large biopsies, will be reduced by providing the laboratory with small pieces of tissue that we have selected, because these tissues will have the tubules, which are more enlarged in size, therefore increasing the chances of having some residual spermatogenesis. Then we need to do something else. We need to do the mechanical mincing, sometimes the enzymatic mincing, because in certain circumstances, we are not able to find the sperm using the mechanical mincing, and then we need to do more processing, which involves enzymatic mincing using collagenase enzyme or DNase enzyme to actually remove the other cellular elements that we are not interested. We are interested in searching for sperm. If there is a contamination with the blood cells, we need to use the erythrocyte lysine buffer to destroy these cells. And we can use also motility enhancement, motility activators like pentoxifylline to be able to identify the motile sperm and therefore viable sperm for ICSI. The laboratory environment is also important in terms of the air quality control, the temperature, pH stability in the culture media, the centrifugation forces, the sterile techniques. And for ICSI, we might need to use some techniques to select the viable sperm for ICSI, in particular, in case we only have immotile sperm. We can use the hyposmotic swelling test, the mechanical touch technique, or the laser-assisted sperm selection. And lastly, we need to use sperm freezing, use small volume carriers, because these patients, they have few sperm. And then we need to save sperm for future, because we don't know if the ICSI cycle will succeed or not. And it will be wise to save every single sperm you could find. So these are some of the things we need to consider when actually looking at the laboratory aspect. One thing that I consider of utmost importance is the laboratory setup, which has to be coordinated with the operating theater. So at Androfert, we have, let's say, the operating theater actually connected with the IVF laboratory. So here you see the operating theater. So next door, I have one IVF lab, and the next door, I have the second IVF lab. These two IVF labs, they can work separately, one doing the routine ICSI IVF stuff, and the other laboratory processing the specimens that I take from the microtizzy. So these laboratories can work separately in a way that you optimize the workload. So you need to have, obviously, more than one workstation for using the micromanipulator, inverted microscope, etc. But you optimize the workload in a sense that you can have the routine in one lab, the microtizzy procedures in the second lab, or if you have a day in which the workload is not so heavy, you can have both embryologists working concomitantly, searching for sperm that from the specimens you take in the operating theater. So this is very nice because the embryologist will provide information about the sperm, about the number immediately. So we never do like the procedures in an operating theater in the hospital and then transfer the specimen to the IVF lab and then wait for the IVF lab to provide us the results. This is like almost, let's say, immediate communication between the doctor doing the procedure and the embryologist conducting the sperm search. So it's very fast, very efficient, and then we are able to kind of improve the efficiency of the process we do concerning microtizzy, which I consider essential to improve the results. So it's not only actually all the aspects that I have discussed with you before, but it's also important the way you actually set up your environment concerning the operating theater and in the IVF laboratories. So with the microtizzy, we take less tissue, as you can see in this slide, in which for tizzy, you see the tissue removed goes even higher than 60 milligrams. And with microtizzy, every piece is like 8 milligrams. So it means that we can decrease the amount of tissue extracted. And remember, tissue represents spermatogenic cells and also Leydig cells. So when you remove Leydig cells, you will compromise androgen production. Patients with non-obstructive azoospermia due to spermatogenic failure, they already have low testosterone production. So when you take large pieces of tissues, you make this patient even more hypogonadal. And this patient might need testosterone replacement therapy for life if you take big pieces of tissue. So it's important to use a procedure which spare the testicular parenchyma as much as possible to decrease, to reduce the risk of having hypogonadism due to loss of testicular parenchyma. The other thing about microTISI that I like is that we provide the laboratory with small pieces of tissue, and as I told you, the embryologists, they can check the seminiferous diameter, and they start doing the mechanical mincing with the tubules more enlarged. So they actually select the tubules using the stereo microscopes and the inverted microscope to start working with, and they go for the enlarged tubules that will actually optimize the efficiency of sperm retrieval. So just presenting you now some results of our center concerning microdissection testicular sperm extraction in men with non-obstructive azoospermia. We have done about 1,000 cases in which the sperm retrieval success rate is about 56%. And according to the predominant testicular histopathology phenotype, as you can see, hypospermatogenesis, maturation arrest, and certainly cell only, this is the success retrieval rate we have got according to the histopathology phenotype. In patients with a non-obstructive azoospermia, when we do microTISI, we always take a small piece of tissue and send to the histopathology because I need to confirm that the patient has certain phenotype that is related to a higher or lower chance of finding sperm. Again, the message here is that even in patients with certainly cell only, which is the worst case scenario, we will be able to find sperm in a significant proportion of patients. So we should not deny these patients an opportunity to achieve biological fatherhood. So concerning ICSI outcomes, we have done approximately 800 ICSI cycles in which the fertilization rate using testicular sperm taken from men with non-obstructive azoospermia is around 63%. So our program is a blastulation program, is a blastocyst program in which we most often do day 5, day 6 culture and transfer day 5, day 6. You see that the blastulation rate is 44% in this scenario, clinical pregnancy rate per transfer 36%, and live birth rate per transfer around 30%. So it's quite a good results consider the severity of non-obstructive azoospermia. What we have implemented recently was sperm freezing using low volume carriers, in which basically we don't use the conventional freezing protocol because you might lose sperm after thawing. There are few sperm, you dilute too much, it's going to be hard to find sperm, and even motility could be compromised. So what we do, we make like a small micro droplet of culture media, like 2 microliter culture media and freezing media, and then we load with the ICSI injection needle sperm in this micro droplet, and then we freeze first in the vapor, and then we plunge in the liquid nitrogen. This is very quick procedure, and this is called cell sleeper because when we thaw, we can actually recover most of sperm that we actually included in each device. So we have got some initial experience with the sperm freezing using cell sleepers in patients with non-obstructive azoospermia. Now we have more than that, but yeah, this is a report of 36 patients in which we included, on average, 11 sperm per sleeper, average from 4 to 60, about 4 sleepers per patient, 1 to 6, the post-thaw motility 70%, and sperm recovery rate around 67%. That according to our data, comparing these results with the conventional freezing method, we have achieved higher, actually, recovery rate and post-thaw motility with the cell sleeper method. At the moment, we have done approximately 50 ICSI cycles in which the fertilization rate is around 50%, the blastulation rate around 50%, and the ongoing pregnancy rate per transfer is about 46%. So it's quite promising results using the freezing with cell sleepers in this group of patients with non-obstructive azoospermia. So one important thing to consider when we look at patients with azoospermia is that ICSI outcomes will depend on the type of azoospermia, the female age, and number of oocytes retrieved. So in this paper we published in 2014, actually we compared ICSI outcomes in patients with non-obstructive azoospermia to patients with obstructive azoospermia, and we found that ICSI outcomes, as expected, were significantly higher in patients with obstructive azoospermia. I showed you before that these patients, they perform as good as patients using donor sperm. However, although the ICSI outcomes among patients with non-obstructive azoospermia are lower compared with obstructive azoospermia, one important thing to consider is that we might be able to increase the chances of achieving a live birth by retrieving more oocytes. Because obviously, in a condition like that, in which the fertilization rates are lower, the blastulation rates are lower, we need to have more oocytes to increase the chance of having a viable embryo for transfer in patients with non-obstructive azoospermia. So recently, we developed a predictive model to estimate the number of mature M2 oocytes, metaphase 2 oocytes, required for obtaining at least one euploid blastocyst for transfer in couples undergoing IVF ICSI. We call this device the ART calculator. So this device might help us to define how many oocytes we need to have for optimizing the results of treatment. So in this paper that we published this year concerning the development of the ART calculator, we actually look at several variables to make the model. We look at patient characteristics. We look at ICSI outcome variables, including all the embryonic outcomes. And we also look at type of stimulation, gonadotropin type, gonadotropin dose, etc., etc. So, and then we come up with a model in which logistic regression analysis selected female age, type of sperm used for ICSI, specifically testicular sperm from men with non-obstructive azoospermia, and number of metaphase 2 oocytes to be included in the model. And then we actually, using the formula, we could estimate the probability of a metaphase 2 oocyte turning to a euploid blastocyst as a function of female age. As you can see in this graph, the probability of a metaphase 2 oocyte turning to a euploid blastocyst decreases with female age. The purple line relates to ejaculated sperm for ICSI, and the pink line relates to use of testicular sperm from patients with non-obstructive azoospermia. So as you can see here, and it's quite clear that the probability of having a euploid blastocyst per M2 oocyte is significantly lower when we use testicular sperm from patients with non-obstructive azoospermia. So in that case, we need to have more oocytes, and the calculator actually could provide that information for us. Here you can see how the calculator works. This is an online calculator that is in the Group Poseidon website, www.groupposeidon.com.br. You just actually, I will go back just for a second for you to appreciate again. The only thing we need to do is to actually input the female age, the sperm source, the success probability of the estimation could be set by the user, and then you need to adjust for the confounders that could be non-obstructive azoospermia, obstructive azoospermia, or none. And the calculator will provide an estimation of the number of mature oocytes with the 95% confidence interval, in this case 11 to 17, needed to obtain at least one euploid blastocyst for transfer. For instance, you have a patient in front of you in which the lady has 37 years old. The husband has non-obstructive azoospermia due to spermatogenic failure. And then, in order to optimize the ICSI outcome, ideally, you should have 14 M2 oocytes, because according to the model, predictive model, having 14 oocytes, you will have at least one euploid blastocyst for transfer. There's no need to do PGT. This is just an estimation. But you know that transferring euploid blastocysts will result in an implantation rate of around 50 to 60%. So having at least one euploid blastocyst will offer the patient the opportunity to achieve a live birth in 50, 60% of cases. So the calculator is just to provide some guidance for the doctor willing to discuss with the patient what is the best approach in terms of the ovarian stimulation that could actually optimize the chance of achieving this metric, which is the minimum one euploid blastocyst for transfer to each patient. Even if you don't do blastocyst, doesn't matter. You need to you could actually use the calculator to decide what is the ideal number of mature oocytes you need to use to achieve, let's say, theoretically, the euploid embryo for transfer to that particular patient. You can do cleavage transfer, you can do PGT if you like, but the model here, the predictive model, is to provide you some guidance. So lastly, I just want to go back a little bit because I want to show you another aspect of the calculator that, for instance, let's say that the calculator says 14 mature oocytes, but you could not get 14 mature oocytes. The patient ovarian reserve did not allow that. You got, in this example here, 6 only. You can calculate post-treatment. The calculator can predict what's the probability of having at least one euploid blastocyst with 6 mature oocytes, or the number of oocytes that you actually achieved. So we feel that this tool could help the doctor to discuss with the patients and set patients' expectations regarding the chance of achieving pregnancy using IVF and ICSI, in particular among patients with non-obstructive azoospermia. So concerning the health of offspring from azoospermic fathers, the results we have in the literature are the data are not very, let's say, remarkable. We have few studies only in the literature, but most studies provide reassuring data concerning the health of offspring using surgically retrieved sperm from men with obstructive azoospermia as well as non-obstructive azoospermia. So we can go ahead with these procedures, but we need to monitor the health of offspring because the data is still limited. Well, in 50% of men with non-obstructive azoospermia, there's no sperm at all, even after using all these steps that I have discussed with you. These patients, they lack any sperm. So they might have only round spermatids, or they may have only spermatocytes, or they may have only spermatogonia. So if the patient has round spermatids, it has been tried to use the round spermatids for ICSI. And this is the group which has the largest experience in the world concerning the use of round spermatid injection And the results are quite disappointing. They have used the technique in almost 3,000 cycles, almost 1,000 patients, and the pregnancy rate per started cycle is only 5.2% in their hands, very experienced hands using round spermatid injection. So the live birth rate per embryo transfer, about 5%. So the effectiveness of round spermatid injection is not high. If you decide to use that, you need to consider that this technique will fail much, much more than succeed. So we need to evolve the laboratory techniques to differentiate these round spermatids to mature sperm to be able to provide better results. And in patients in which we don't have the round spermatid, the only hope is stem cell therapy. Although we have achieved some results in the animal model, concerning human stem cell therapy for men with no round spermatid and no sperm, well, we don't have anything to offer at the moment. These studies and several studies conducted using embryonic stem cells, using somatic cells that have been transformed in pluripotent stem cells. Well, the different research groups, they have achieved stages like primordial germ cells, gonocytes, spermatogonic stem cells, haploid-like cells, but up to this point, no mature sperm have been actually achieved using stem cell therapy, and therefore, no results concerning ICSI. So we still need to kind of improve the stem cell therapy to offer hope for men with non-obstructive azoospermia in whom no germ cell was, in terms of round spermatid or sperm, were found after sperm retrieval. So in conclusion, ladies and gentlemen, I want to give you some key points related to non-obstructive azoospermia due to spermatogenic failure. First of all, this is the most severe male infertility condition. However, in 50% of men, we have minimal intratesticular sperm production. So if we are able to harvest testicular sperm from the seminiferous tubules, there's an opportunity to use such sperm for ICSI and result in viable offspring. So the optimal management of men with non-obstructive azoospermia seeking fertility. Well, I have gone through every single step, and it starts with the proper differential azoospermia diagnosis, and then we need to go for genetic testing using Y chromosome microdeletion testing, and counseling about the chance of finding sperm, or even deselecting a patient with AZF-A and B microdeletion from treatment. Then we need to identify those men in which we could offer hormonal modulation prior to sperm retrieval or varicocelectomy. These two interventions could help selected men with non-obstructive azoospermia to achieve better outcomes. Then we need to use the most effective sperm retrieval technique to harvest sperm from the testicle, which in my opinion, and according to the literature as well, is the microdissection testicular sperm extraction. And lastly, we need to apply the state-of-art IVF techniques that I have gone through. So in essence, it's a coordinated multidisciplinary effort involving every one of us, from the male infertility specialist standpoint. We need to include also the geneticists, reproductive endocrinologists, because it's very important to optimize the ovarian stimulation in terms of number of eggs, the embryologists. So it's the nurses that will be actually helping these patients with the hormonal modulation, taking the medication, etc. So it's essential that this coordinated multidisciplinary effort could make a difference and change the fate of men with non-obstructive azoospermia desiring fertility. So in future, we hope the stem cell research could create the artificial sperm that might give hope to some men with complete what we call aspermatogenesis, which is the complete lack of round spermative or sperm. So thank you very much for your attention. It was a pleasure having been discussing this very exciting topic, azoospermia, with you. Thanks a lot. Well, this is a question related to the hormonal modulation in patients with non-obstructive azoospermia, in which the patient could get even testosterone below, if the testosterone is below 300, ideally you should start with HCG. This is the starting point. So every time you have a patient with testosterone below 300, you start with HCG. And then monitor 1 month later the hormone levels and see testosterone levels, how they are, estradiol levels, how they are. And if the testosterone to estradiol levels are below 10, continue giving HCG and then add aromatase inhibitor. In that case, could be anastrozole, as mentioned there, 1 milligram once a day. Well, if the testosterone levels are higher than 300, okay, and the testosterone to estradiol levels is below 10, starting with anastrozole is a good option, because you will be able to increase the bioavailable testosterone, and also it will improve the intratesticular environment by having more intratesticular testosterone. However, every time you give anastrozole alone, in my experience, you won't be able to help the patient much. The best results we have got was with the use of recombinant HCG or HCG. My experience is only using recombinant HCG. I don't have experience with urinary HCG in this group of patients, because in our condition here, the patients want to use the self-administration at home. I like to titrate the medication. Sometimes I decrease the dosage, which is very convenient. So I prefer to use the medication which is pure. Well, but yeah, you can, if the testosterone levels below 300, go for HCG. If the testosterone levels is higher than 300, you need to check how higher they are, because if it's just above the thresholds, I still like to give HCG, because my target level in terms of total testosterone will be between 500 and 800 nanograms per deciliter. So you will not be able to achieve those target levels using anastrozole. For that, you need HCG. But yeah, if the testosterone levels is like 500, let's suppose, and the patient is obese, overweight, and the estradiol levels are high, you can start with anastrozole alone and then monitor the results 1 month later, and then continue with anastrozole alone if the condition improves. So the second question is related to if I advise microTZ instead of testicular sperm extraction in all cases. This is a difficult question, because as you have seen in the presentation, there is a group of patients who has a good prognosis in terms of sperm retrieval, and these patients are those with hypospermatogenesis. So let's say now that you have a patient in front of you coming from a different center with a histopathology report showing hypospermatogenesis. Well, this patient most likely will have sperm using testicular sperm extraction. So you might actually, for this particular patient, start the procedure just doing, you can expose the testicle, deliver the testicle, expose the testicle, doing a biopsy, taking the sample, sending to the IVF lab. So if you have the setup the way we have, the IVF lab will be able to provide you the results within 5 minutes. And then you can see if you just take more biopsies or you need to convert the initial testicular sperm extraction to microTZ. So in good cases, in good prognosis cases, like hypospermatogenesis, and also patient with history of positive sperm retrieval, you might consider starting the procedure with TZ and then converting to microTZ if needed. So, I mean, you can do a stepwise approach to the procedure. In my hands, I always advise the patients for microTZ instead of anything else. So in our scenario, I do microTZ in all cases with non-obstructive azoospermia. My approach is once and done, which means I want to do the procedure that could extract as much sperm as possible to allow cryopreservation using the cell sleeper method and to allow multiple ICSI cycles. So my approach is to offer the patient just one sperm retrieval procedure. In this procedure, I will be able to collect objectively, extract objectively the areas more likely to have sperm production. I will increase the sperm quantity that I could harvest. I will be able to optimize the cryopreservation method, allowing the laboratory and the gynecologist, the reproductive endocrinologist, to kind of offer the patients multiple ovarian stimulation cycles if needed until a pregnancy is established. So is there any role for Johnson scoring in prediction success rate of sperm retrieval? Well, Johnson scoring is an old scoring concerning the histopathology report. You can use that because when you have more advanced scoring, it's more likely to have more advanced spermatogenesis. This is okay. But I prefer a simplified scoring in which the pathologist will provide the results in terms of the predominant and the most advanced histopathology phenotype. For instance, the pathologists we use in our center, I have discussed with them, because the service is provided outside the clinic, they provide me a report in which they say what is the predominant histopathology and what is the most advanced histopathology that they found in the analysis. I asked them to provide me an estimate of how many cross-sections of seminiferous tubules they could identify in the biopsy. So the report comes like that. We have looked at 200 cross-sections of seminiferous tubules from the left testicle, in which the predominant histopathology was maturation arrest. And the most advanced histopathology was hypospermatogenesis, or it was mature sperm. So I know that in that particular case, I should be able to find sperm in the microTZ. By contrast, I can have a histopathology report saying, we have looked at 90 cross-sections of seminiferous tubules, in which the predominant pattern was Sertoli cell only, and the most advanced pattern was, again, Sertoli cell only. They could not identify anything else. Even in this situation, you have 20% chance of finding a spot of spermatogenesis inside the testicle by microTZ. But I know that the chances for retrieving sperm is quite lower in that particular condition. So in summary, we use a simplified scoring system in which the pathologists report the number of cross-sections of the seminiferous tubules they look at. They provide us information about the predominant histopathology, meaning hypospermatogenesis, maturation arrest, certainly cell only, or tubular hyalinization. And then they provide us with the information about the most advanced histopathology they found in the biopsy. That could be hypospermatogenesis, maturation arrest, and then also again, certainly cell only. So it provides us a good scoring system for prediction of sperm retrieval success. So there's another question by my colleague, Dr. Miyaoka, who works with me, and he's asking when to use clomiphene citrate. Is there a baseline gonadotropin value that would preclude its use? Clomiphene citrate can be used to increase FSH and LH levels. I mean, if you have a patient with we are talking about non-obstructive azoospermia now, and if you want to do hormonal modulation, we can give clomiphene citrate. There's no baseline gonadotropin value that would preclude its use. You can give for a patient with even high FSH LH levels. Well, the problem with clomiphene citrate is that it will increase the FSH levels even higher. It will increase the LH levels in some patients. By giving clomiphene citrate or any other estrogen modulator, the testosterone levels will reach the ceiling level. It will go above 800 nanograms per deciliter, which is not good, and could even block spermatogenesis. So if you decide to use clomiphene citrate, which I don't like very much, because it's also associated with more side effects, you need to monitor the endocrine profile very closely, because in patients with testicles which are not very small, you might trespass the ceiling level. And the other important thing that I consider is that when you increase too much the FSH levels, you might actually internalize the FSH receptors in the Sertoli cells. So it might cause the situation even worse. So by giving HCG therapy, you might actually decrease the FSH levels, because as I presented in the two cases I shared with you, the FSH levels were above the normal ranges. So when I give HCG and start actually increasing testosterone levels, the negative feedback in the pituitary will actually reduce the FSH serum levels. This is excellent, because then you are resetting the system, and then at the Sertoli cell level, the FSH receptors will start to pop up again, and this is a good thing to promote spermatogenesis. Recombinant HCG. This is another question from another doctor asking and making a point that recombinant HCG and in certain cases FSH can be very expensive. I fully agree, especially given 2 times a week, 3-6 months. This can amount to another IVF cycle already. How about your experience with clomiphene? Yes, this is the situation that I have discussed before. If ever, what dose you give, and will you monitor the same parameters? Yes, you need to monitor the same parameters. I try to explain the problems with HCG. A lot of doctors actually explore HCG. If you decide to use clomiphene, start with 25 milligrams per day, 25 milligrams per day. So if the pill comes as 50 milligrams, just ask the patients to split the pill in 2 and give half pill per day. Monitor the same way. And then if you see that the testosterone levels are going up above the ceiling, you need to decrease the clomiphene to every other day, 25 milligrams every other day, and then you need to kind of keep giving. Well, it's going to be much less expensive than giving HCG and FSH in case we need to give FSH, but the experience has shown that this is not, at least according to the experience we have collected at Androfert, this has less success rate compared with a recombinant HCG. Not all patients will need FSH. Only about 1/3 of the treated patients will need FSH to be added. So regarding HCG alone, and then if the patients will stay with HCG alone, it won't be that expensive. It will be perhaps 1/3 of an IVF cycle in terms of the expenses if the patients stay with HCG alone, but still could be expensive for some patients. What you need to consider is give a proper look at the case. So if you have a patient in which, try to select the patient to do the stimulation. So if you see a patient in which the patient has got previous testicular sperm extraction or previous testicular sperm aspiration, and that case was not successful, or the doctor could find only abnormal sperm, very few sperm using, let's say, conventional sperm retrieval methods. So this is the ideal candidate to start with, let's say, HCG therapy, because these patients will be the ones with low testosterone levels, very high FSH. And in these patients, if you do the hormonal modulation, you can rescue a negative case that's coming from another center to you, and you might rescue that case and provide a live birth for that couple. That could be fantastic. So I would recommend you to select some patients, such as the one that I just mentioned, as the eligible patients to start with the medication, get some experience, and then perhaps as soon as you get more experience and you have more confidence that the medication might make a difference, and then you can move to kind of offering the treatment for more patients. Okay. Do we have to surgically bring down undescended testes before starting medical management in non-obstructive azoospermia? Well, I think this is a very difficult scenario for sperm retrieval. If you have an adult patient with undescended testes, more likely you will not be able to find any sperm unless the patient is young. I have seen some cases in which we have done, especially because I do a lot of surgeries in the Middle East, and in some cases I don't have the opportunity to do the surgery to bring down the testes or even the hormonal modulation. In some cases, I do the surgery, the microTZ in the undescended testes. I have found sperm in very few cases in which the patients are very young, around 20, 30 years old. And then we have got two successful cases in that particular clinical scenario. But I would advise against doing sperm retrieval in patients with undescended testes. I do believe that the best options will be in patients who had orchidopexy done at early age. So if the patient comes to you as an adult with undescended testes, well, you actually need to discuss with the patient the possibility of, first of all, put the testicles down and wait, let's say, at least 6 months. And then you can actually discuss with the patient again the possibility of doing any intervention. One option in this case, if you have the patient with undescended testes, you might actually do a biopsy during the surgery, during the orchidopexy. And during this biopsy, you send to, if it's possible, to do the surgery in the IVF center, or sending the sample to the IVF center to have a look at, the IVF center could actually take some part and send to histopathology report, and then have a look in the remaining specimen to see if there's any germ cell there. And then accordingly, if there's any sperm, you can freeze. If there's no sperm at all, you have the histopathology report. And the histopathology report could be very informative, because if I have an undescended testis patient in which I push the testicles down, and during the surgery, I took the specimen, and the histopathology report told me that the patient has maturation arrest. This is an excellent case, actually, for doing hormonal modulation and doing micro-TZ later on. So in these patients, the answer will be, ideally, we should bring the testicles down. So if you cannot bring the testicles down because of the patient preference, because of costs, etc., and you go for the micro-TZ, you need to advise the patient that the chances of finding sperm will be quite low. Yeah, this is the same thing. I think I have already answered that one. You can start with clomiphene citrate, do the monitoring as I said. But again, if you have an opportunity to use the HCG, try HCG in some selected case. I believe you'll be very happy with the results you might achieve. So there's another question about okay. Exactly. I mean, the best option would be to start with recombinant HCG or HCG alone, irrespective of the testosterone estradiol ratio. So the best patient to start with will be patient with low testosterone levels. So check testosterone levels. If testosterone levels are below 300 nanograms per deciliter or 17 nanomoles per liter, then you give recombinant or urinary HCG. As I said, my experience is towards recombinant HCG, but it's more expensive, I agree. But also, we can titrate the dose much better. So in this condition, start with low dosages. You don't need to add much. Start with 1,000 units twice a week, and then 1 month later, 3 weeks later, you do the monitoring. And then if the testosterone levels goes up, you need also to check estradiol levels concomitantly. So when you do the hormonal analysis, order both testosterone, estradiol, in addition to FSH and LH levels, because you need to see if LH levels are going down. And if the testosterone to estradiol ratio is below 10, you might need to add 1 milligram per day anastrozole. It will be decided later. Along the same lines, addition of FSH will be decided later, because only 1/3 of patients might need FSH to kind of overcome some severe pituitary inhibition that the increase in testosterone level will promote. So not all patients will need FSH. And again, I need to stress that the hormonal modulation for patients with non-obstructive azoospermia is still considered empirical treatment, because we have evidence coming from retrospective cohort studies, prospective cohort studies, but we still need a prospective randomized controlled trial in which we provide treatment or go ahead and do sperm retrieval directly to see the beneficial effect of the hormonal modulation in a prospective randomized way. I myself utilize modulation, hormonal modulation, quite frequently. I have got good results. I'm convinced that this is a good, let's say, conversation we need to have with the patient to improve the success rate of sperm retrieval. But still, in terms of advocating as a routine, we still need more data to kind of confirm the clinical utility in using hormonal modulation supported by randomized controlled trials. Are you still with me?
Yes, sir. One more last question. So, like, since there is no much of randomized control trials, okay. So, I feel like then Indra can also join you in doing some studies, and we can start maybe from our level also, and we'll collect the data, and then we can bring out some good studies because we have a good number of such cases of NOA.
I think it's an important point to discuss. I think I would suggest, if you allow me, that first of all, you collected all your case of because you have huge number of patients across all clinics. And the first thing you could do is create a database in which you collect the data, perhaps you already have it, of all the NOAA cases in which you have done the conventional approach that you utilize at the moment. Let's say that you go ahead and do the testicular sperm extraction directly. And then we need to understand, first of all, what is the baseline success rate you have got with the procedures you do. So after that, let's say that the sperm retrieval success rate is 40%, just for an example for discussion. We need to calculate the sample size for this prospective study based on the baseline levels you have got, and then we can calculate the sample size accordingly, because we need to say, okay, I will provide the hormonal modulation, and I expect to increase in 10% the success rate according to the baseline. So it's very important that you collect some data according to the type of sperm retrieval you use. And if you use any sort of hormonal modulation like clomiphene citrate, that information should be included as well, because then we need to stratify your success rate according to use or not of hormonal modulation. And another thing that I suggest is that you stratify the sperm retrieval success rate also per testicular histopathology phenotype. Because let's suppose that your patient population has a lot of patients with hypospermatogenesis. You are very lucky. You are getting lots of patients with hypospermatogenesis. Well, your sperm retrieval success rate in that condition should be higher than 70%, because you were lucky enough to have a population predominantly of hypospermatogenesis. On the other hand, if you are unlucky to get so many patients with sertolizumab only, your sperm retrieval success rate in NOAA patients will be 20%, 25%, 30%. This is not because you are good or bad. It's because of the characteristics of your patient population will actually impact on the success rate, sperm retrieval success rate. So it's important also to analyze the sperm retrieval success rates according to the histopathology. If you are not actually taking a specimen and sending to the histopathology report as a routine, I advise you to start doing that immediately. Because as I showed in my talk, and I always try to present the results stratified by the histopathology report, is that I have seen papers and doctors reporting variable success rates according to the sperm retrieval methods. And some doctors, they say, well, I have got the same results that you have got with the conventional TZ. And then my next question is, what is the proportion of patients you have with sertolizumab only? Because in my case, in our center, is more than 50%. So if my overall success rate is 56%, as I showed you, and my population is heavily contaminated with patients with sertolizumab only, well, I think it's very fairly good success rates that we are reporting. So I think it's important to design a study, as you suggested. I fully agree. It's important to understand what is the baseline success rate in your scenario, and also to understand what is the stratification of your NOAA patients concerning the testicular histopathology results. Yeah, I have some. Yeah, I think this is an also important point. We can do. I believe so. That in patients with severe oligosteanoteratosospermia, you need to see if there's any role for recombinant HCG. The answer is, it depends on the testosterone levels. If you have low testosterone levels, so the patient has hypogonadism, you might explore the possibility of giving these patients recombinant HCG to kind of improve, let's say, the intratesticular testosterone production and eventually the spermatogenesis as a whole. There are some studies actually looking at including giving these patients some FSH to improve sperm DNA fragmentation. This is something that I will discuss next week. But I think for severe oligosteanoteratosospermia, no motility, I mean, if you exclude any causes, let's say, that could be treated like varicocele, so no varicocele, this is like idiopathic OAT with no motility, you might actually explore recombinant HCG using the same dosage that I presented before.
So,
yeah.
So one case is there. In that particular case, there was a severe oats with no motility, and this person was determined to go with the self sperms only. So we have done ICSI twice, but every time get any sort of embryo. And in this particular case, we thought of doing giving recombinant HCG. Testosterone was evaluated it was less than 300, so we started with recombinant HCG. And after the 2 months of treatment, testosterone level had gone up to the 200, 800. And then again we have decided for the to take the ejaculatory sperms and use for it for the ICSI, but result is the same. So, is there any role of TISA after once you have achieved the testosterone level 800 or so in such cases?
I think so. I think I would advise you to go for testicular sperm. One important thing to discuss in the case that you presented is that the ceiling level concerning testosterone level is 800. We should never go beyond that level, because then you start blocking the pituitary. So it's like you are giving testosterone exogenously, like testosterone replacement therapy. If you have a normal adult in which the patient is complaining of, let's say, weakness, something like that, and the urologist prescribed testosterone, this testosterone levels will go above 800, giving testosterone exogenously. So it will block the pituitary, and then you get hypo, and this patient will have azoospermia most likely. So every time you give HCG, start with low dosages. Do not go beyond the ceiling level of 800. Try to stay around 600. So you can titrate the dosage accordingly, and then stay a little bit away of 800. Well, going back to the case, there are some data supporting use of testicular sperm in patients with severe oligozoospermia and the cryptozoospermia. The newest systematic reviews and meta-analysis support evidence from observational studies. There are no randomized control trials that in patients with severe OAT and cryptozoospermia, results are better with testicular sperm instead in preference over the ejaculated sperm. So I do think that in this case you are discussing, I would go directly to testicular sperm. The only issue in patients with severe OAT, cryptozoospermia, is that sometimes the testicles are quite small, and the best option in terms of sperm retrieval would be go for biopsy instead of the needle aspiration, because if testicles are small, there's an increased risk of creating hematoma by the needle aspiration. There is an increased risk of taking too little testicular tissue by needle aspiration, and you might find out that it could be hard to find enough sperm for ICSI. So I would recommend in this particular case to change from ejaculated sperm to testicular sperm, no doubt about that. If this case were conducted in our center, we would actually go for testicular sperm immediately to improve the outcome. And then in that case, I would prefer taking sperm using conventional testicular sperm extraction, not needle aspiration. I do believe that in these cases of oligoastenoteratozoospermia, in which you see idiopathic condition, the testosterone levels are not very low, well, there's a limited benefit of doing hormonal modulation. You might increase a little bit, but in these cases, well, sperm DNA fragmentation could be high because these are infertile patients with a dysfunctional epididymis quite often, and then you might have a problems in terms of sperm quality that could be actually could be overcome by taking sperm from the testicle. I will try to discuss next week some new data about use of TISA or TISE for cases like that, and I will try to bring you and share with you the literature that is available supporting the use of testicular sperm.
So at Indra, what we do is we keep the dose of the recombinant HCG constant, like 250 milligram throughout the treatment. But we go right now with the lower dose, start with the lower dose, and later on then titrate as per the testosterone and T/E ratio.
Exactly. Do not, yeah, I think it's too much. When you give 250 micrograms per week, well, this is excellent for a patient with a hypo, as I presented in the study we published. These patients, they need more stimulation, fine. But the patient with non-obstructive azoospermia, they are quite variable. So if you give as a routine 250 micrograms to all patients, you are kind of over-treating. You are pushing the system too much. And some patients will actually trespass the ceiling level of 800 nanograms per deciliter total testosterone level, will actually make the situation even worse. Do not do that. So we start low. So if you have the recombinant HCG available, is it a pre-filled syringe or you have it in the pen?
Yeah, we are doing with the syringe most of the time.
Syringe. So what you need to do is start with half syringe. So you can actually ask the patient, because you have nurses. So the nurses will teach the patients to actually use the syringe twice. Now we have the pen device, because now recombinant HCG comes in a pen or a pre-filled syringe. In our country, we now have the pen, which is quite convenient because you can titrate in small dosages. I can even give very small dosages using the pen. Well, to do that with the pre-filled syringe, it's more tricky, but can be done. The only thing you need to do is the first injection. is half dose. So if you give half dose, you are giving actually 3,000 units. Then give only half dose per week. And then the second half dose that the patient keeps in the fridge or it keeps in the clinic, the patient could come in the clinic every week to take the shot, if possible. So the nurse will actually just aspirate the half dose that was remaining in the pre-filled syringe, because you cannot remove the needle and put another one. It comes with the needle attached to it. You cannot actually replace the needle, unfortunately. So the nurse will have actually to prepare and to aspirate the liquid and then make the injection with the remaining half dose. So I would recommend you not using the full syringe once a week. Do not do that. I have done that many times in the past. And I have experienced situation in which the testosterone levels surpassed the ceiling level. It was not good. So I changed my approach completely. And I'm doing the way I presented in this talk, starting with small dosage. You can even give, you take the syringe, the pre-filled syringe, and split in 4 dosages. Very easy. Just take the full content of that pre-filled syringe, and then load for, let's say, 1/4 in 4 different insulin syringes and give to the patient ready to use. The patient keep in the fridge, and the patient can take once or twice per week. This is what we have done before the pen device being available to us. So the nurse prepared the dose ready to use. I mean, you can play with the medication. So it will make the treatment cost less expensive, because you'll be able to titrate the ideal dosage for each patient. And you learn that the response will be quite variable. In some patients, they will do well with, let's say, small doses per week, which makes the treatment more convenient.
Okay, sir. I think that finishes our session, and most of the questions been answered. And it's really a 2.5-hour job done. So it's salute to you, sir, for giving us so much time and sorting out our queries. Thank you, sir.
Thank you very much for all of you who have been watching this webinar for so long. It was a pleasure actually interacting with you. And I hope to see you next week for our last webinar, which is going to be the surgical and medical management of male infertility. Have you all a lovely week. Thank you very much.
Thank you, sir.